Hey, everybody. It's been said that the only constant in life is change, and medicine and this podcast, no exception. So since this was recorded in 2022, there's been some changes to the EMS protocol that aren't reflected in this video. The first of which is TXA. Although all the administration and all the other philosophy about TXA discussed in this video is absolutely correct, the dose is now changed from 1 gram to 2 grams, given in exactly the same manner described in this program. The second is push dose epi. Although in the program we refer to 10 mics every 2 to 5 minutes, that is now changed in 2 ways. The first is the timing is completely abolished. As soon as you know you need the drug, you can go ahead and give it to stabilize your patient. Furthermore, you may give up to 50 mics per dose as your patient requires to stabilize their blood pressure or heart rate. Hope you enjoy this operational pharmacology podcast.
I think Dr. Spanner's point's really good, though, too, for those squads that always ask, oh, my transport time is this, and I think it's good we talk about how long is rocuronium going to stay? How long is, if you didn't have RSI and you don't have rock and you had ketamine and you have the Versed, I think you give a good treatment path for those paramedics that are 20 or 30 minutes away. How do I manage this, right? I'm going to get that patient in the back of the ambulance. I'm going to give them the ketamine. I can perform the intubation. I'm going to set my Untitled up. I'm bagging them. I'm good to go. Now I'm headed to the ER, and then I have a plan. In my head, I should know, hey, in about 20 minutes, I might have to go to that 2.5 of Versed, which is easy to dose. There's that follow-up benzo, or if you want to follow up with more ketamine, you have that plan, because a lot of times when we're out teaching CE, it's, okay, well, you do that, and then how long does that last?
Well, this has been coming up a whole lot more just with one little change in the protocol, and that was the anticipated loss of airway. That word gets changed, and now it's like, oh, if I can even anticipate this, I can give the ketamine and take somebody's airway. Well, so these questions have been coming up a whole lot more recently.
Yeah, and that was really to tune that more for the inevitable loss cases, right? Or the patients that are some respiratory failure, right? Yeah. They're not moving any, they're breathing, but you put your hand over their face. They're clearly not moving any. Right. Their sats suck. Their capnography's through the roof.
Right.
But they're still a little with it, right? And that's really...
Or they have trismus, or something that I just can't get past.
That was, that was my original question to him was, who do we execute this on? And it's really those patients, because if you walk up, you sternal rub them and they do nothing, they don't have an airway. They don't need ketamine, and we can go straight to airway management.
Or if I throw an oral airway in them, even at the basic level, and they tolerate it, I probably can take their airway.
Correct. That's exactly it, right? And those are patients.
I can't tell you how many tongue depressors I go through on a shift, right? If I
put all the popsicles you're eating.
I mean, the nurses know if I'm taking. Well, they're bigger than popsicles. Although I sure would like a popsicle
that size,
that big, right? But if I'm putting that in and they're not even gagging on it, I don't need anything.
Exactly.
It's going to be
a good judgment call.
Right.
And like you and I have talked before, Scott, I can recall 4 cases now in this year that I could have used.
You've had quite a run.
I've had quite a run. I could have RSI'd somebody, but it wasn't there. So the moment that we actually get the medications in our box, I'll never need it again. And I'm waiting for that day.
Yes.
That's actually great for the patients.
Yeah. But the reality of it is, because this is a national conversation, and the conversation is, should we be doing RSI? Well, head-to-head studies, and I'm speaking one specifically from Australia, where they did pre-hospital RSI and not pre-hospital RSI, the long-term outcome for appropriate RSI actually showed that those patients did better. Now, you can certainly find other research that says they didn't.
Conflict.
And the reality of it is we believe with our education and with our oversight, and ensuring no hypotension, ensuring no hypoxia, that our patients are doing better, because they're getting the same treatment they would get in the emergency department with highly trained pre-hospital providers.
Yeah, that's a continuation of care.
Exactly.
It just makes sense.
So for our airway cases, 100 milligrams minimum.
Minimum.
Right? So if I've got a 50 or 60 kilo patient, I'm not going to do the math and come up with 60 milligrams and you want to start with 100 on that patient, right? Because we've got a very wide therapeutic range with that once we get into the disassociative range, and it's safe. So we're going to give 100, which is 1 milliliter of the concentration. We only supply one concentration.
Right.
That's that's 500 milligrams.
Well, we
and
found
5
that
milligrams.
when we've had drugs,
When
and I'm
we've had
speaking
mul-
about Versed.
Yep, absolutely.
Remember we had the nasal Versed and the IV Versed?
Yeah.
I cannot tell you how many oversight errors we
Yep.
found in that. That we find that if we stick to one concentration, we reduce errors.
Absolutely, absolutely. So 1 milliliter at a time, 100 milligrams, and if they need, repeat 1 milliliter, 100 milligrams.
Right.
Yeah. All right, that brings us to the next big high dose use, which is the violent patient.
Okay.
And Caleb, do you have anything else that you wanted to touch on about that?
Not particularly. I
saw
think
you
as
brought
with
that out.
any time we would use ketamine particularly, let's make sure that we're setting up our equipment first. Don't treat the machines, treat the patient. But at the same time, capnography is paramount. SpO2 is definitely paramount. And if you're going to make an airway attempt, put the nasal cannula on high flow and let that blow in as we're getting, and definitely hyperoxygenate,
Right.
like you said. Limit your attempts. I like to talk, when I did RSI training with Garlisi, one of the things I talked about was hold your breath during your intubation attempt. If you need to breathe, they've needed to breathe. So time it.
That's a really good thing to do.
And use that as a time point. I have to take a breath. My patient has needed to take a breath. So that's about all I have.
I would
think
say-
you have big points too on setting up. Not to interrupt you, Doc. A lot of people, it sounds like such a small thing. Is be prepared, set it all up first.
But
it's
it's
just,
not.
it's
It's huge.
not. It's as easy as hit the lead button and it should be pre-programmed on your monitor. I want to see 2, 3. And instead of looking at AVF now, I want to see my end title. I want to see my waveform.
Right.
You're supposed to plug the end title into the machine first, let it calibrate, and then put it on the patient. If you talk.
And we could
to
do the
physio
2-3-3
specifically.
rule and kind of get an idea
Yeah.
exteriorly,
Yes.
but we're not going to know what an airway looks like until we get inside.
No.
So have your Bogey ready.
Yeah,
If you have it, have your 2 different blades ready.
100%.
This is
Video
not-
or endoscopy
this
ready.
is
if
not
It's
it's
all
ready.
National
part of the
reg-
P's, right?
This is not
Prepare.
National
Yeah.
Registry.
No, you are now
Prepare.
dealing with the real life. We can't.
This is not National Registry. Cheat.
When I intubate,
Cheat.
I have
Take
a king tube
bring
ready to
all
go
your-
just in case.
Exactly. Bring all your tools out.
Cheat.
Have
You're
some-
right.
And cheat. Take a look before you go to
Your
it.
suction
That
suction
drives me
machine better be
nuts.
running and have a
Absolutely.
tip on it ready to go. I mean, you should, get the patient into the proper position. Take your time. If you can take somebody's airway, get yourself set up for success.
That first P is the
I
most
agree.
important one, isn't it?
Mm-hmm. It is. It truly is. Because all that stuff, now, if you're in there, like you said, hold your breath, I need something else, right? Then now I have to find it. I have to open it. I have to get it. And then what happens to our patient, right? We have to pay attention all the time, make sure they're oxygenating well. It's just, it seems like such a small tidbit, but
And not
it
to
sets
mention
you
the
up for
overzealous medic or basic has been bagging and putting 90% of that air in the
Right in their
belly the
belly,
whole time. And
Yeah. Yeah, just going to lead to another complication. Yeah, we don't need that. I agree 100%.
Yeah, my kind of pet peeve there, and the thing I think we do a poor job, certainly as instructors, reiterating, is they hurry up and get that airway maneuver done rather than taking a minute or two to optimize the scene for first pass success, right?
take a breath.
But as simple as right,
Time out.
tactical breathing,
Yeah.
right?
There's nothing wrong with a timeout.
So in my personal case, when I get over adrenalized, my left hand starts shaking. It's just my thing, right? I know that, right?
Too much Mountain Dew.
It's just you get super. I know my hand will start shaking, and I just gotta sit back. I look up, couple of deep breaths, slow my heart rate back down, and then I'm fine, right? But to optimize the scene, it may be as simple as rather than try to do that intubation on the floor, just put them on the cot. Now you're looking right down their airway as you're doing your laryngoscopy,
Yep.
right? Now you can maneuver them. You can get ear to sternal notch alignment. You can do all these other things you couldn't do on the
And
floor.
in all
and what did that
honesty,
take us? Another
Good
60 seconds.
technique bag valve mask works.
Yeah.
And if it's working, why screw with it? So be in position of comfort. Get to your office. Take them to your ambulance where I'm most comfortable. I'm not comfortable on your kitchen floor.
Right.
So take your time.
Yeah, very few cases. Now there are those cases, but they're very few and far between where the basics aren't working, right? And you can set up, take an extra minute or two and get it right,
Yeah.
right?
Yep.
And prevent that too from going in the belly and being unrecognized, God forbid. Or,
There's very few emergencies that improve with somebody getting overexcited.
hurrying up.
Doesn't work.
Right. We were transitioning to
Agitation.
tranquilization doses, yeah. So,
Okay.
Yeah, so I think the first thing that we probably need to tease out is that column under behavioral emergencies is very specific to violence. There's a column for combativeness and there's a column for violence. How do we differentiate?
I would like
those?
to look at it this way.
Yeah.
Are you in immediate danger? Is the patient in immediate danger? If not, what are you doing? So I'll give you a great example. I was at a jail recently kind of reviewing their medical policies for prisoners. And there happened to be a prisoner in the restraint chair. And he was screaming about God and the devil and voices. It was frankly obvious, and thank God I happened to just be doing an inspection. And it's just weird how these things happen, right? Right person at the right place, I guess. And I said, could we call 911? And the jailer's like, oh no, he'll calm down. I go, it's not a calming down situation. It's a mental emergency. This is a mental illness emergency, and he needs to be treated like you would treat any medical emergency. So the squad came, and they were saying, Doc, do we need ketamine? And I go, he's in a restraint chair.
He's tied down already.
I mean, how many times have we seen someone wanting to use ketamine and somebody who's handcuffed? I mean, they don't need ketamine for that, because are they really going to hurt you? Now, if that same person is banging their head against the side of the ambulance and they're going to get an intracranial bleed or a skull fracture and you have to protect them, by all means, that person needs ketamine. And then they need proper monitoring and proper everything else that goes along with that, and proper evaluation, including glucoses and everything that we do with altered mental state. So what I saw was a fully restrained patient who was diaphoretic, who was hearing voices, who was an acutely psychotic individual.
Psychosis.
I followed his case on the EMR, and he was positive for amphetamines and cocaine. So he was completely drugged out, psychotic. The drug there is not ketamine. The drug for him was a B52. Now, this squad did not carry Ativan, but we gave, and you can do this a couple of ways. We gave 5 of Haldol IM, 50 of Benadryl IM, because he was kind of out of control, and 2.5 milligrams of Versed IM. And within 10 minutes, he was calm, placed on the cot, and he was calm all the way to the hospital. Now, we not only appropriately treated him, we helped his illness. Mm-hmm. And that's what we're supposed to be doing here. We're supposed to be helping our patients' illnesses. And if you treat a patient with respect, you're going to get to the right answer appropriately. If you run into a place and say, he's out of his mind, let's give him that ketamine, when he comes out of the ketamine, he's going to be worse. So not only did you help the psychosis, you actually worsened the psychotic event. So what is your reasoning? If you're about to be hurt, or they're going to hurt someone else, and the danger is imminent, that's when I use ketamine.
I've heard, as you described here a minute ago, these patients, if you give them ketamine, that they can, again, once that wears off, right? I've heard that described as crazy down, crazy up, right? If they're swinging and out of their mind, this isn't going to help treat their illness.
Yes.
It is just going to make the scene safe for you temporarily. They ultimately
very temporarily. We're talking 15 minutes.
They need other agents to
Yes.
treat the illness.
Yes.
Well, like you said, we need the other agents. We need to know our toolboxes and what's in them, because
Yes.
there are other agents that are going to work even better.
This is not a one and done thing.
Exactly.
Yeah, there's more of a story.
And a
behind it.
B52 is what you needed.
Oh, the other one I wanted to mention was, some people call it 5-5 instead of B52, which is 5 of Haldol and 5 of Versed. And those two doses in combination intramuscularly are also an exceptional thing to do, although you don't control any dystonia from the Haldol if you don't add the Benadryl. So sometimes 55 and 5.
So something we were talking about a little earlier, what 3 can we put in the tube together? What 2 can we put in the tube together?
Okay, so good question. When I'm using Haldol, it doesn't mix with anything. Okay, I don't mix Haldol with another drug. I keep that completely separate.
So
Yeah.
2 syringes.
Yes.
syringes.
I don't usually mix Versed and Benadryl, so for me, the B52 is a 3 syringe event. But the 5 and 5 is 2 syringe event. Ketamine works phenomenally and mixes very well with succinylcholine. So one thing I do with trauma is I'll take 100 of Sux, and Sux is 20 milligrams per cc. So succinylcholine, I'll take 5 cc's of succinylcholine, and then you have 505 cc's. 1 cc of ketamine is now 6 cc's in a syringe, and you can give both of those all at once in one syringe. So now you've done a disassociation and a paralytic, boom. And then you can also mix the rocuronium and the ketamine. So it's handy that way.
As far as triggers, historically, I've heard you use the analogy like when to utilize ketamine at the 250 milligram dose to protect ourselves,
Yes.
right? To safe the situation.
Yes.
If you had a taser, would you use it? You've said that.
Oh, yeah.
on
No,
board.
that's
Yeah.
like if you were sitting there wondering, oh my gosh, I wish I had a taser. This person's going to kill me. Or I wish I had a taser. They're going to jump out of the squad. That's somebody that deserves a ketamine dose and then proper post-ketamine care.
My mindset on it is if I backed up, it's a theoretical exercise. Of course, there's not many a place to back up in your ambulance, but if I back up, will the threat follow me? Is kind of
Oh, that's a nice one.
That's kind of my
Yeah, I like
no
that.
go for is this the right agent
Mm-hmm.
of choice? Because oftentimes patients are reacting to our attempted medical care, right? They're thrashing, they're kicking, they're spitting, because we're trying to get a blood pressure, trying to put a pulse ox, trying to get a glucose, et cetera, et cetera. And those are the patients that we would go first to
Yes.
a B52. And how about if we have done hard restraints on a patient?
Yes.
All right. Always follow that up with chemical, or should we just let them?
Oh, no. If you have somebody properly restrained and the threat is gone and they're not trying to rip out of the restraints where they would injure their skin, cause traumatic damage to their extremities or themselves, no, they don't need anything. Now, that being said, if I had somebody, and I've done this, that was cooperative, for example, and they were saying, these voices won't stop, and I'm like, are those very uncomfortable for you? And they're like, yes. And I said, I have a medication that could take the voices away in 10 minutes. And we have a melt-away olanzapine,
That's right.
Zyprexa. If they're willing to take that in restraints, that is a wonderful drug in our box. And I use this a lot in the emergency department, but they have to be minimally cooperative. Could you please take this? It'll melt under your tongue. It'll get rid of the voices. And it's very hard to reason with a psychotic patient. However, they can be reasoned with. Usually all people sense empathy. And when you show somebody that you care, they become trusting enough to help themselves with your plan. So Zyprexa, olanzapine, nice drug. We have the 10 milligram melt-away, and that's usually a very nice dose. It should be remembered that it looks very similar to Zofran and ondansetron. So both generic names start with O. Both trade names start with Z. Both look very similar. And I actually have had to review with a squad when they gave Zofran instead of Zyprexa.
The vomiting patient was no longer noxious.
No, they weren't nauseous. I don't think
They
they
didn't
cared
care.
at
But
all
they didn't-
about
They
it.
didn't care about their nausea.
We still
right?
want
Not
to
a
use
bit.
the right drug at the right time for the right patient in the right route.
And one of the things that we try to do to correct that, with the look-alikes, sound-alikes, and the design of the drug box is, if you look at an ALS drug box, each little cubby, if you will,
Yes.
the drugs are supposed to either A, go together, or B, be polar opposites, right? So if we want to talk anaphylactic reaction, epi and Benadryl. Together, go with that. And then we could flip to racemic epi and low pressor, right? Just complete opposite ends of the
opposites,
spectrum for a safety feature. One of the things that we did with Zyprexa, it actually came out of Geaugas Pharmacy. Ashley helped us with it. is Zyprexa should be in a clear bag in our squad's drug box with a bright green label that says this is Zyprexa, or it'll say Zyprexa.
Is that system-wide?
So we're trying to move it to all system-wide, yes.
See, Ray,
To
that's the
institute
kind
it.
of stuff that fixes problems. That's exactly what we're talking about. Good.
And that's the kind of stuff that's coming out of your medical direction reviews,
Yes.
though. So it's working. And
Yeah.
that goes back to the reviews of ketamine. I mean, stuff like that gets brought up and solutions are made.
And
Yes.
it's a team thing too. That's where we bring the pharmacy into a lot of this with it. You know, hey,
Yes.
how can we fix this? How can we prevent it? You know, and Ashley was like, "What do you think of this?" I love it. Great, let's do it to try to
Spot on.
prevent that incorrect medication being given. So it's excellent. To touch on the Zyprexa thing, one of the things we brought up in our con eds I didn't want to bring up. Zyprexa is not for panic attacks.
No.
So that was one of the things that I know we pushed really heavy with our
Psych-
Well,
education.
we
To
didn't
go
we
back to the
fix the
first
wording?
column.
Didn't you guys fix the
We
wording?
did.
Yeah.
We did, but it's just also good to review some of the people that might not, maybe they missed that con ed, and maybe they don't read the
Mm-hmm.
protocol as much, you know. Zyprexa is not for a panic attack. So just concentration ketamine, if you will, 505, right?
Right.
So for my violent patient that is throwing us around, or we're afraid of,
Yes.
or backing up, or we're trying to truly protect them from hurting themselves or somebody
Yes.
else, you know, our first dose would be 250 milligrams IM, so that's 2.5
2.5
cc's or
milliliters.
2.5 milliliters, and then we could follow that up in 5 minutes as a repeat dose if we needed to. And that was one of our changes as well. It used to be 3, we've increased it to 5. And let's say you give that patient the 250, they have a positive response to it, they calm down. Piggyback on the end title again, because I'm very pro end title. That is a requirement for all of our patients as a
Yes.
safety measure. We want to make sure that we're doing that. But we've had good, just from some of the charts I deal with on the pharmacy side, we've had a very good response with 250.
250 alone.
I've seen you see a lot more than I do, Doc, but I haven't seen a
Occasionally.
ton. I haven't really seen a lot.
occasionally you'll see that second dose.
Probably in like the 20-30% range. It's not.
Yeah, it's not.
I
a
don't
lot.
think it's that high.
Yeah,
No,
it's not. That
I
heavy.
agree. I think it's actually probably
Probably
lower
less
than
than
20.
I gotta poke the bear here a little bit. You give them the first 250, they are still awake, but they are no longer a threat.
You're good.
We're good, right?
Right.
This is
our-
all about
our-
imminent danger.
Our goal here is not to make them out and asleep, and that
No.
No.
there's that misconception. We watch too many
No.
movies, right?
Yeah.
They
It's a
get
good
stabbed in the
point.
neck and then they just pass out.
Yeah, but also, would you
will-
agree with me that our goal with Narcan is not to wake them up either? It's to restore respiration. So
Correct.
True.
I wish I could get everyone to get that, because it is such a terrible thing to go from overdose to withdrawal.
yeah,
Immediate
and then
withdrawal.
dealing with that is very difficult. So I wish I could get everyone to be on board.
you showed
on
me a
that
snippet
train.
of somebody that gave how much? It was of Narcan.
What was that? 65 or 69 or something like
Yeah.
that. It was absolutely nuts.
Oh my God.
At what point too do we say it doesn't work? Let's go to
Correct.
something else.
So there is something stronger than fentanyl. Why not, right? What is it? Carbafentanil. There's one. There's carfentanil that is actually 50 to 100 times stronger. So I can't wait for that. So you may find yourself using higher dose Narcan, but the reality of it is, once you get them breathing and they're
We're done.
controlling their airway, you're
Yes.
done. This is not a wake up, let's take an IQ test, okay? This is just control your airway and breathe.
And then translate that to the ketamine thing would be, they're not violent anymore. They're not going to hurt us. They're not hurting themselves. We don't need to give any more drug. And I think, Scott, you bring up a great point. I think a lot of people are, I'm going to give him this. I'm going to give him this shot,
And
and
they're
he's
gonna
going to
be
he's going to be
out.
out, unresponsive. He's going to sleep the way
That's
to the
not our
hospital.
goal.
And that's not what we want to do.
You've
Our job is
overdosed.
to protect the patient. Yeah, you truly have.
Yeah.
You've overdosed. them,
Wait,
and it
say
doesn't
that again,
benefit.
Ray, what you just said, because I don't think that came off the mic.
Our goal is just to protect the patient. They're not going
Thank
to harm
you.
themselves. They're not going to harm us. We've calmed them down enough. Yeah, they could still be awake, but we're not trying to snow them. That's not what we're trying to
Exactly.
do. We're trying to
Keep
protect
the
them.
patient's best interest on the top of your list every time.
The flip side of that is sometimes they get the 250 and
Oh yeah,
they're snoring.
100%.
That's okay, but you've already put in play your capnography, your pulse oximetry. You've checked their glucose.
Yes.
You've done all your EKG monitoring, every last bit. I mean, even our EMT, EMT squad wouldn't be doing this alone, but they've got all those same tools with the exception of the EKG.
And I think one of the things that Doc brought up early on too, and talking about that case in Colorado,
Yes.
don't get tunnel vision, right? So now we've gotten to that point where we are cooperative, right? I don't care if it's an overdose or if it's that violent patient now. All right, what is their blood sugar? What is their blood pressure? Do we need to do a 12 lead? Let's not get that tunnel vision. Well, it has to be an overdose.
It's never just one
It's
thing.
it's just this because
never-
dispatch said it is.
yeah.
No, don't stop. Keep going.
Yeah.
Keep trying to find something else wrong with it. They could be. I'll use Andy Garlicis. They could be septic, right?
Seek and you will find.
I just keep looking.
Yeah, you'll miss 100% of the stuff you don't look for.
100%.
Yeah.
Some people just, I stopped here. I got my tunnel vision and I'm done. And that's not what we want. We want people to keep looking.
The altered mental status protocol is
Oh.
really just
Huge algorithm.
a go find protocol,
Yeah.
right? It is just a
It's a geocache.
do IVO2 monitor glucose 12 lead capnography, and then go find one of how many different etiologies for causation, right?
100%.
And attack them.
We all know that our worst call is an altered mental. It's that and abdominal pain.
So we covered the dosing, but I don't think we actually covered the pain dose. For
We haven't got there yet. I think one last thing for the high dose stuff. There is one very notable polypharmacy reaction with ketamine that we have to be highly suspicious of, and that's alcohol. Alcohol and ketamine don't like each other. So if you have to, if you have that violent alcoholic,
Right.
just make sure your BVM's close because there may be some transient apnea or
Absolutely.
protracted apnea. So, and you've done nothing wrong. It's well documented that ketamine and alcohol don't like each other.
And with this and also the Airway, remember tools like the RAS score. We should be doing the RAS score and documenting where they were and where they were after giving ketamine, as far as the Richmond agitation sedation scoring.
Not real time though. This is
Not
something
real time.
This is something to help quantify
Our
your
need
approach, your
and-
need in your charting. Right?
But it needs to be charted, yeah.
Yeah, absolutely. All that's spelled out on the key points page in
Yes.
the protocol, right? Because not everybody has. a
But
good
as easy
memory.
as the RAS score is, it's something we can do afterwards for sure.
Absolutely.
It's
But
not brain.
I think that was it
I think
for the
that's it, I
high
think.
for the
high dose, yeah.
disassociative stuff. So
I think we're just moving.
I guess
into
we're on to
pain
pain.
now.
Yeah.
Yeah, ketamine for pain.
I guess
Okay.
we're on to pain. We started a little bit with that, but we can't use the same. We can't use the same concentration. Well, in theory, we could use the same concentration, but it's
That'd be really hard.
if we're starting with 10
I don't think you could do it.
You need like the little
challenge
insulated
accepted.
syringe.
Give me a 1 ml syringe.
Yeah, I'm going to pass on that.
So, we're going to be starting with doses of 10 milligrams, and if that's 100 milligrams per milliliter, we'd be needing to pull
Where
off.
did it go?
That's right.
That's
Oh,
right here.
okay.
We'd be needing to pull off a tenth of a milliliter.
Yeah.
And I would screw that up. So
You'll lose that in the needle.
exactly. It'd be neat if there was a easier way to do this.
There is an easy
There
way
is.
to do
There
it.
is an easier way. You want to do?
Go ahead. It's easy. You can get it.
What do you want?
Even I can do it. I just need just give me that needle right there.
Why don't you use one of these? Because you're not going to do it with an angio. It caps itself.
I don't know that you'll
No,
get that in
that's
there,
fine.
will you?
I won't get that in there. That's
No.
not a. So what we're going to do is we're going to take this from 100 milligrams per milliliter, which is from 100 milligrams per milliliter, which
There's
is
an actual needle. Okay.
it's 505. And one of the things that we got to remember to do is we're demonstrating. Remember, this product's going out audio too, so now we got to describe absolutely
Oh,
everything.
okay.
Everything,
Yeah. Yeah, they
everything
might
that
not
we're
see the
doing. So,
video,
what I have here is just that single vial of ketamine, 505, which is 100 milligrams per milliliter, and then I also have here just a standard 10 ml flush, which standard off the shelf stuff, standard off the shelf flush. You need a needle and you need an alcohol prep. And what we're going to do is we're going to take this and we're just going to divide it down. We're going to make 10 milligrams per milliliter. And honestly, I heard the term first from you, Ray, a long time ago, which is, the concept is push one, pull one, right?
Yep.
And we're
Give
going
one.
to, we're going to pull we're going to push 1 milliliter out of this 10 ml pre-filled saline. So I've got 9 mLs in it. So
Okay.
we're just going to, there we go. Let's see here. Push that down to 9 mL. So we got 9 mLs in there. We're going to ready our ketamine here.
Is it left hand shaking?
No, not adrenalized at all. Calm as a cucumber, man.
You gotta get over.
I didn't say it
12
happened.
Mountain Dew
I didn't
instead.
say it happened often. I just got to be aware of
Mid Mountain Dew.
So we sterilize the.
Yeah, so
the
yeah,
ketamine.
just sterilize that with your alcohol prep. And we're going to draw up 1 milliliter out of here. Now this 1 milliliter I can just pull out of here. If you try to put a milliliter of air in here, it's actually going to get kind of tricky.
Because
Right?
there's saline in it.
Yeah, because it's loaded with saline, right? So this is one of those cases where you may just want to pull that back to 10. There we are.
Give it a little shake.
Now, the rub here is when you put that cap, you got to put that cap back on. If you do that, if you put the cap back on that syringe after you, or that pre-filled after you draw up that medication and you shake it, I'm doing it right in front of the microphone, you can't hear anything shaking. That's because there's no place for that. There's no air in there. There's no place for that ketamine and for that saline to mix. So overdraw this. Now this is tricky because I'm sure we've all done this at some point as we've pulled too far back on a saline flush and we've lost 10 milliliters into our lap, right? Or onto the floor of the truck. So pull that back, but don't pull it out of the back of the syringe. So you've got another milliliter or 2 of air in the top here. Then when you put that cap on, now you can clearly hear that that's getting agitated in there, and I'm mixing this down to 10 milligrams per milliliter. I've taken 100 milligrams. Now it's divided in 10 total milliliters, yielding 10 milligrams per milliliter. Now I'm just evacuating that air out of there, and now I've got 10 milligram per milliliter. And then I can give this via whatever route.
Push one, give one.
Yep.
Right?
Yeah.
Push
one, pull one, give one.
One every milliliter is 10 milligrams.
Yeah.
Yeah.
And now, when it comes to wasting, we have to waste this,
Plus you have to waste.
and we have to waste that vial, right? So we've got 400 in this vial plus, let's say I gave
It's
one.
not the patient's doggy bag to take
So-
home.
Yeah, this is not consolation prize.
I know we're not supposed to use names, but to this moment I'm going to give credit to Solon Fire Department, okay? Because you're only allowed to give this 3 times. So their motto is push one, pull one, waste 7, and then give one at a time. So
Oh,
they
okay.
can never give more than 3
So
doses.
they don't give too much. That's the
Yeah,
way.
I thought that was a cool
That's a
thing.
good
that
idea.
they
You gave
did.
me that Sharps container over there.
I like that. That's good. One of the things too we did with this on the mixing
Thanks, bud.
that we looked at was we actually used Mio. We just used water
Right,
instead of
yeah.
ketamine
Yeah.
and that. And we wanted to see how well it actually mixed when you drew the ketamine into
Yeah.
the saline. It mixes pretty well, so that's why I think it's very important you talk about once you've drawn the 100 milligrams of ketamine into the syringe and you've recapped it and you leave that space now. It's just an added bonus to make sure we roll it around because pharmacy doesn't like the word shake all the time. They yell at me all the time.
point.
We have to watch the shake part.
Roll.
But the
Roll this in a linear fashion.
Yeah, roll this in a fast fashion to make sure it mixes all the way because we don't want to push one, pull one, and then now my 100 of ketamine sitting at the end of that syringe.
Yeah,
right?
basically you got
So we
100
want it
sitting on top
to
of
mix a
9.
little bit. We want it to dilute down to that 10 milligrams per ml.
Yeah, that's a good
and,
point.
And it actually mixes pretty well when you draw. So we've always built in that extra buffer that Scott's talked about, which I like. I think
Okay.
it's a good safety. I like the Solon thing.
Yeah.
I've never heard that. I like that. That's
I like
good.
that.
I will say use caution because we're pretty good about saline flushes, right? So you hold on to the ketamine one, and then now I pull another flush out of the box. Then I turn around, I talk to the patient, then I turn back around, and now I have 2 syringes that look like saline flushes
Wow.
sitting on my bench seat.
Wow,
right?
wow.
So is it give one, see if it works, give the other one, see if it works, right? We don't want to do that, but it could happen. So what some of our squads have done that I've seen them do is they'll peel off like part of the label of ketamine, and they stick it on the syringe.
Oh,
So
very
then
nice.
that tells me, hey, the
Oh,
ketamine,
that's a nice
the
idea.
ketamine's in the syringe,
Yeah.
and it's just because it's readily available.
I like that.
That's all. So you have to just be cognizant of which one. Yeah, magic
Take,
marker,
take,
put
take
a
your
K,
Sharpie, right?
something, just
Should have a
because.
Sharpie on your ambulance.
Because, if you're given that
Probably.
the reason I bring this up, because if you're given that drug, right, I start an IV, and let's take it away from, I'm not worried about giving so much fluid replacement, right? So your motorcycle crash with the femur fracture, if it's hemorrhagic shock case, I'm probably going to start an IV, give a little bit of a fluid bolus. But if I just did a hep lock, and now I want to push one, and then now I want to give my one, it's in the lock, right? Because there's 2 mLs that's in that saline lock. So you thought I gave that patient a dose of ketamine, but I really didn't. It's sitting in that saline lock because you need 2 mLs to flush it entirely. So the flush comes into play, but let's just make sure we try to label the syringe as well.
And Giaga, at least in their pharmacy, they do give us labels for any medication that we might mix that we can peel and stick.
Yes.
And
In the drug
if for some
box, or-
reason,
Okay.
if there for some reason wasn't one for that, we could take a piece of the back of it and stick it on the syringe
Yeah.
and write. And I've done that.
Yeah, our guys use it just because it's readily available.
Yeah.
It's easy. One of the guys I ride the squad with does that all the time. He'll do it with fentanyl. Anything he draws up, he's always sticking the sticker on it. And I like that. It's a good idea.
That's a good idea.
Then there's no question if you say it's laying in their lap when we come into the ER, you're like, what's in this syringe? Oh, there's ketamine in it. Okay, so we know.
The what you spoke to about basically charging the hep lock with the drug. We're using ketamine because we're talking about it, but it could be anything, right?
Oh, it could be any drug. Yeah,
absolutely
sorry.
anything. And then we're just going to ram in the flush. Well, you've just basically, you've just fast pushed whatever that was.
Yes, you got to watch.
And nearly every single medication reaction that's out there, most all of it is rate of administration problems. If you do most any of these drugs correctly, they're generally pretty safe, assuming you've got the
agree.
right drug.
They're pretty forgiving.
But my person, I absolutely will go out of my way to spike a bag and have that running if I'm giving any meds, just to prevent that same situation. So there's always a bias flow going through there, and it's being carried with the patient. I'm just not charging the hep lock. Right?
Yeah, and that's good. And I like the saline thing. I just know a lot of providers lean towards the hep lock thing, so I just want to bring it up.
No, it needs to be said. Yeah,
Just because
that's just
I think
my practice.
No,
That
I
doesn't
like
mean
that.
It has
I like
to be
that.
everybody's
Giving
practice.
some saline's good, even if saline TKO, it's good. And
I
it's,
shut it down when I'm done. Right?
yeah, it's putting it in a nice steady rate. It's not slamming it into the patient, if you will. Yeah,
Yeah, I'm not
I agree.
hanging, a full liter bag either, right?
No,
It's just
no, not by any
250,
means. I didn't
500
take it that
bag.
way.
Yeah. It's just just enough to get some flow. So we talk 10 milligrams at a time, up to 30.
3.
What if I have a really long transport time? What if I'm 30,
Call med control.
30, 40 minutes? Can I give more?
That's actually
No,
perfect.
that's exactly that was the
That's what we do. We call med control and
right.
we ask, "Hey, doc, I've given my 3,
And we'll say yes.
and
That's-
I've got 20 minutes because of a snowstorm.
Right.
Can I give another 2?"
Yeah, and I think that goes back to the paramedic school point. You know, when you get there and you have that patient that's injured, and I want to give them that drug, you need to know how long it's going to hang out with them for. Ketamine, fentanyl, how long is this going to stay with them? And those providers that just want to go to giving that large loading dose, you're still going to lose that in that amount of time.
15 minutes.
15 minutes, it's going to go away. But you can always give smaller increments and then give it over time. So
Yeah.
if I give 10, and that's going to give me 15 minutes down the road. And if I give 10 more, now I'm 30 minutes down the road. Right? And then that might avoid the call, but never be afraid to call medical control. A lot of paramedics,
Like I like to
for
tell
some
my
reason-
students in class, we all need to be masters of our trade, but the only time we cannot use registry or use med control is at registry. So use it.
Yeah, 100%. Don't be afraid to call and ask. I mean, that's what they are there for, those unique situations.
I think we talked about this in the last episodes, right? And just call with a plan.
Yeah.
Right.
I mean, you were speaking to this.
Organized.
What was it? Two or three CEs ago, where it was, we tell you this incredible story, and you're like, "Great, I have no idea what you want."
Right.
I have no idea what you
Ask
want.
what we want.
Yeah.
Actually, the ones that
Succinctly
get
state
what
what
they
you need.
want are telling me at the
What they're going
beginning
to
of
do.
the
Yeah.
call.
Yeah.
Like, Doc, I need this medication.
For these reasons.
And so already I know what they're looking for.
Yep.
So those are the medics that are getting positive med control reinforcement. If you're calling up in a busy emergency department where somebody's managing 20 patients and you want their undivided attention, you're only going to get that if you direct them. Because we're busy.
Yeah. Yeah. I am doing this. I need your permission.
Right.
Boom, boom,
Yeah.
boom.
Here's
I need
why
to
I'm-
exceed the 30 because of my time. Can I give another 10?
And for the
Yes,
EMS
boom.
side too, get your ducks in a row.
Yeah.
And know what you're asking for before you make the call. Take a breath. He's just a human too.
Right.
Yes.
Hey doc, this is what I got. This is what I think I need to do.
Yeah, because when you call and you're like, so I have this, and you want to have this leisurely conversation,
Well,
and you're
yeah.
running a code.
How
in a
are
room,
you
you're
today?
Like, just how long before you're here? 10 minutes. Okay, don't do anything.
Yeah,
Just bring 'em
exactly.
here.
Right.
Because
That's
don't
what's
sound
gonna
confident.
happen.
They don't sound confident.
No.
They sound panic, or they don't know what they're doing. And
Right.
you sound nervous. You're not going to say yes to that.
And why would he?
Yeah, I don't
Yeah,
know.
or succinctly state, I'm stuck between here and here.
Right.
I don't know which way to go.
Yeah.
I know I need to do one of these things. I just which direction do I go?
I would say most medics are actually pretty good at telling us what they want, because then it happens. The newer folks might have a harder time on that, but it comes.
Repetition.
Right.
It's
Yeah.
And I hate to sound old school here, but I think we've lost a little bit of that savvy with cell phones. When you were forced to give a radio report
Yes.
and it had to be succinct, and the entire county was listening to you.
You're a little more nervous.
I tell you what, you either got really good or you sounded like a complete jackass over the
Yeah.
radio.
Yep.
It's true.
And now we talk to so many people
Right.
All the
on
time.
the telephone, right? You approach it just like you were saying. It's
casual.
Like, it's casual. It's like,
It is.
Here we're coming. It's like,
Until you're in the valley and you can't get a signal and you're forced
Right.
to do it. And you're like,
Yeah.
oh.
I'll call him after in hopes he says yes.
I'll just text med control.
Yeah.
Excellent control. Thank God that's never happened.
Yet.
Give
Hasn't
give Dan a
happened
little
this week.
time. Yeah.
All right. One last thing about ketamine and specifically documentation of the violent patient. Just documenting that the patient was combative is wholly unsatisfactory, right? I mean, there needs to be a description. You need to make the sales point of why this agent was chosen for that, or any agent in that.
Yes.
I don't even say, we're looking at this from the ketamine angle, but specifically, you need to sell that violence in your narrative, right? That just can't be, hey, we saw the guy was combative, so we stabbed him with some ketamine. It needs to be
Justified.
completely justified.
Documentation.
You mentioned the RAS score. That's good. Kind of
It's a good
post-
evaluation to
post-hoc,
know how
yeah.
sedate the patient
Yeah.
is
And where they
how
were to begin
aggressive
with.
they
Where
are.
they were and
Where were they at the beginning to require that? So that's what I use that for.
Right.
Usually a good history and documentation covers that.
Yeah.
When I teach the paramedic portion on documentation, I like to stress the fact that we're painting a script that we need to be able to recreate, having not even been there. So if we're sitting on a jury stand, or if we're sitting somewhere, that picture is painted to the point where I can recall it 10 years later if I need be. And the only way you're going to do that is to paint a picture, and everything needs to be documented. If it didn't get documented, it didn't happen.